Hello, my name is Grayson Amarato, and for Case Connection 4, I will be discussing cases 2 and 3. So let's take a look at case 2. Here we have a 4-day-old infant, also known as infant A, that has demonstrated high levels of phenylalanine during a newborn screening test. Her diagnosis is phenylketonuria, which causes issues with the metabolism of essential amino acid, phenylalanine. Under normal conditions, phenylalanine is hydrolyzed to our non-essential amino acid, tyrosine, by enzyme phenylalanine hydroxylase. This enzyme requires BH4 as a cofactor, and deficiencies here can lead to PKU. The biochemistry of PKU begins with mutations on the PAH gene that generates phenylalanine hydroxylase, which converts phenylalanine to tyrosine. Tyrosine then becomes our essential amino acid, with issues with phenylalanine metabolism. Without working phenylalanine hydroxylase, the amino acid phenylalanine builds up to toxic levels in the blood and tissues. Seizures, delayed development, behavioral problems, intellectual disability, and psychiatric disorders are common symptoms of PKU. Babies born to mothers with PKU are at significant risk of intellectual disability. Nerve cells are particularly sensitive to phenylalanine levels, which explains how PKU can cause brain damage. The range of severity of the condition is due to mutations on the PAH gene that allow the enzyme to retain some activity. In our patient, after phenylalanine-restricted diet therapy was initiated at 14 days of age, plasma phenylalanine levels dropped within normal range, confirming that this was indeed an issue within the enzyme phenylalanine hydroxylase. However, there is a second potential cause of PKU, and this could be from issues within the required cofactor BH4. And this is needed for the metabolism of phenylalanine to tyrosine. Deficiencies with BH4 could lead to elevated levels of phenylalanine, thus causing PKU. These patients are not clinically responsive to a phenylalanine-restricted diet and need specific substitution therapy. We have a second patient here, infant B, who has also been evaluated for suspected PKU. And a BH4 loading test was conducted on both infant A and B. Looking at the results, infant A is in blue, infant B is in orange. And we can see a steady decrease of circulating phenylalanine after BH4 was administered in infant B. And this indicates that the root cause of infant B's PKU diagnosis is deficiencies within the cofactor BH4. Since levels of phenylalanine did not decrease in patient A, deficiencies in cofactor BH4 is not the root cause of infant A's PKU diagnosis. And that concludes case number 2. So looking at case number 3, we have a 47-year-old man who presents with severe pain in his right toe. Based on physical examination and laboratory findings, he is diagnosed with gout. His blood sample suggests elevated plasma urate and below normal levels of urinary uric acid. Gout is a disease resulting from the deposition of urate crystals caused by the overproduction or underexcretion of uric acid, decreased salvage of purines, or overproduction of purines. The best explanation for the presentation of gout in this individual would be the overproduction of purines. The disease is often associated with elevated serum urate levels, the main causes being either lower excretion of uric acid, higher synthesis, or both. Metabolic situations with higher production and circulation of such acids are accompanied by the hypoexcretion of uric acid in urine, indicating that there could be deficiencies with glucose-6-phosphatase and or fructose-1-phosphate adylase. Deficiencies involving glucose-6-phosphatase from gluconeogenesis or glycogenolysis traps glucose-6-phosphate in the cell and is either oxidized through glycolysis or the pentose phosphate pathway, or increase in substrates will lead to an increase in PP to increase nucleotide production, thus increasing purine synthesis. This is associated with lactic acidosis, which elevates the renal threshold for urate, and the increase in uric acid plasma that is seen in our patient. The underexcretion of uric acid can be explained by the competition of the body trying to excrete both lactic acid and uric acid. Our patient also says that he usually drinks between 4 to 5 liters of soda daily, and this could have significant impacts on his gout presentation. With fructose and a high fructose corn syrup being the primary sugar in most sodas, a higher fructose intake could elevate plasma urate levels. Fructose increases fatty acid and triglycerol synthesis, VLDL secretion, and increases LDL cholesterol. Fructose loading in the liver causes sequestration of inorganic phosphate fructose 1-phosphate and diminishes ATP synthesis. As a result, there is less inhibition of de novo synthesis of purines by ATP, and uric acid formation increases. Fructose-induced hyperuricemia is associated with a decreased renal uric acid excretion, which is consistent with the urinalysis. The two other causes cannot be a root cause of this patient's gout. Specifically looking at the decreased salvage of purines, this can't be a root cause because this disease involves typically manifests between 3 to 12 months of age. And major characteristics of decreased salvage of purines include overproduction of uric acid, motor and cognitive disability, and self-injuring behavior. Our patient only exhibits one of these characteristics. The second, decreased urinary excretion of uric acid, is primarily caused by excessive alcohol consumption. The metabolism of excess alcohol increases lactic acid production, which does not compete with uric acid to be excreted. The levels of lactic acid caused from excessive alcohol consumption is much higher than the levels of overproduction of purines. And this patient does not note that he does consume alcohol, so this cannot be our root cause.